certified in family medicine and addiction medicine. He is the medical director of the Assisted Recovery Centers of America. He serves on the boards of the St. Louis Regional Health Commission, St. Louis Criminal Justice Ministry, and Alive and Well Communities. Dr. Rottnek is the program director of the St. Louis University Addiction Medicine Fellowship. Please give a warm Marion welcome to Dr. Fred Rottnek, please.
It is a pleasure to be here today. First time to Ohio, much less Marion, so I started in the right place.
Yeah.
Let me know if you can't hear me okay. I taught high school before I went to medical school, so I'm used to having my voice carried. And since we're among friends, I'm going to get rid of the jacket. Hopefully nobody will be offended. I always feel like it's Halloween. It's kind of like a white coat. A white coat's good for photos, and that's about it. So today what we're going to talk about, first of all, I could not have a better setup than what I had with Jan and Dan just now. Because I could retitle this slide, Operationalizing Hope with Addiction Medicine. Because we're going to pick up on a lot of the themes and the things that need to change from what Dan and Jan were talking about. And we're going to talk about medications, but more importantly, we're going to talk about raising the bar on goals of treatment for people with substance use disorders today. And don't worry, not too fancy. I like to talk about Lego blocks and things, so we won't get too technical. No financial disclosures, and I won't be advocating for any off-label uses of medications. All right. So what we'll do today, we'll talk about the role of medications in the care of folks with substance use disorders. And I'll say SUDs usually, so that's what I'm talking about. We'll talk about discuss lessons from somatic chronic disease states, in other words, physical disease states, and how can we apply that to working with folks with substance use disorders, and then also creating a working model for wellness and recovery that aims for flourishing. Dan asked earlier, what's the technical term for thriving? We can call it flourishing. Thomas Aquinas would have said flourishing. But the goal is, we need to raise the bar on what we think is a treatment success in the U.S. when we're working with folks with these issues. Okay. This is a slide that SAMHSA puts out, the Substance Abuse and Mental Health Service Administration, where we talk about health, recovery, and wellness. This is the one time of the many times I will say this phrase, that healthcare is necessary but not sufficient. Might go back to high school geometry. I think that was part of our theorems, right? Necessary but not sufficient, or in logic. You need to have it, but it's not the whole story. And even though I'm focusing on medication pieces today, I think of medication as the exact same thing. For people who need medication, who have medication in recovery, it's necessary, but it's not sufficient for thriving. Prochaska's trans-theoretical model. I just like saying Prochaska's. Okay. Everybody has seen versions of this. This is one model of recovery. Okay. One model for behavioral change. Pre-contemplation, it's not even on my radar yet. Contemplation, I think I need to consider changing this behavior. Pick your behavior. Contemplation is thinking about it. Preparation is getting ready for that change. And if you quit smoking once, twice, 3 times, when I always tell my patients, you want to quit smoking, get your car detailed. It costs money. It's an investment, right? There's things you can do to prepare for that quit date. Action, put that behavior into action. Maintenance, keep that behavior maintained. And then relapse is now a part, actually it was originally a part of this model, but as part of what we're talking about when we talk about health maintenance. Now, the reason that I focus on these 2 slides are kind of level setting to let you know where my head is. Healthcare is just part of what defines wellness. We talk a lot now, fortunately, about social determinants of health or social influencers of health, which is a little more politically correct term, even though I always say life's too short to be politically correct, so you've been warned. But things, social determinants, things like housing security, job security, food security, relationship security, all those things that we think about in terms of what we would say somebody's life is doing well. And we'll come back to that. Now, why do I have a behavior change slide up here? Because I firmly believe that almost all of our health decisions are behaviorally motivated. My work wife, I have a work husband and a work wife at St. Lucie. I'm very fortunate. But my work wife is a behaviorist. She's an educational psychologist. So she doesn't want to hear about it unless there's a behavior that happens and gets assessed. I think it's something that we can look to Pavlov for, right, or Skinner, who were psychologists in conditioning. But we can also look at liberation theology, if you want a whole nother discipline, where we talk about do the right thing and you come to believe the right thing, okay? So behavior is extremely important. So supporting behavior in this context of broader array of what wellness looks like, I think is a real key when we look at health interventions that can support people, all right? But my question for today is, let's compare what management looks like for chronic physical diseases, and we're going to compare those to substance use disorders in just a moment. Again, Dan and Jan kind of set me up for this. When we take addiction and behavioral health and other issues out of the moral failing bucket and put it into the disease or condition bucket, that gets rid of a lot of crap, right? Too often in the U.S. as in other parts of the world, for the longest time, if somebody had a mental illness or somebody had an addiction, it was considered moral failing. People were weak, dumb, lazy, stupid. We all got some of this stuff hardwired into our heads at our kitchen tables growing up, right? By moving to talking about addiction as a chronic disease, it frees us up with tools to look at through the lens of intervention. Because guess what, folks? When we go to the moral failing end of things, that allows us to go, not my problem, they did it to themselves. Okay? In this crisis, we're actually starting to talk about some of it now. So what we do with physical health, think about hypertension, chronic heart disease, think about diabetes. We don't want people to think all day long, ooh, I've got my blood sugar under control, I'm good. We want people to live the life they want, right? Not worried about their meds all day long. We want to help them through our team members, through families, to be successful in managing their health. And if they relapse, so we don't often use that term in physical health, but if they relapse, think about somebody who's got their blood sugar monitor. If it reads high, do we pull that insulin from them and say, obviously you weren't serious about taking care of your diabetes? Okay. We don't, but too often we do that with folks in recovery. And we play games with meds, we play games with access into services, and we get the outcomes that we designed the system to create, which are pretty rotten. So this is an opportunity to kind of reframe some of those by looking at this. So again, in medicine, what do? Traditional healthcare, we give people the tools they need to self-manage a disease. Here's your meds, here's how to use them, here's how to lose weight, here's how to go to physical therapy, occupational therapy. These are ways to move you towards a treatment success. So my question then becomes, why do we manage things so differently in working with folks with substance use disorders? Whoop. Get a little carried away there. Okay. Why do we manage things differently? No good reason. Okay. I always let people know when I send my slides ahead, there is a blank slide in there and it's intentional. Okay. And it's intentional because this is the inertia that we've had for so long in our society. Okay. Now, is the opioid epidemic the first substance epidemic we have had in our lifetime?
No.
No. Can anybody think of another one? Alcohol, meth, crack, coke, tobacco, okay? And our new favorite one that we're legalizing to get the cart in front of the horse, we won't need to go there. Vaping, okay? That's another one too, okay?
Go on.
What's different about this one? Rich white kids in the suburbs are dying, okay? The previous epidemics, in my lifetime, I know that when it came to meth, crack, coke, and a few other things like that, including alcohol and tobacco, we let generations of young people either die because there was no treatment options for them, or we went into a period of hyper-incarceration. 1980s, any of you can think back that far, we had 3 things happen that shot up the trajectory of incarceration from slightly increasing to boom. Okay? Those 3 things: Just Say No, traditional DARE programs, traditional ones, what do? No effect, or kids start using substances at a younger age, yet we still fund them. Okay. Just Say No, 3 strikes and you're out, and mandatory minimums. Mandatory minimums meaning legislators, usually from good intentions, would say that if somebody had a drug-related crime, the judge has to follow guidelines that we as the legislator put together. And those of you who know this work know that we still have laws on the books where crack is milligram for milligram. People get a sentence 8 times longer or more severe than coke. Why? Because legislators thought that we could use a sentencing guideline as a deterrent for drug use. Hello. Jan and Dan's story will tell you, when your head's not there about what your cravings are controlling you, the last thing you're going to look at is a judicial decree, right? Okay. So lots of opportunities there. So let's move forward to see where we can go. This is a magic slide that if you guys remember nothing else from today, then this slide, I've done my work. Why? Because this is a slide I'm socializing for any event that will happen these days, where we start looking at comparing somatic chronic. I want people to have the kind of life they want and need and not be obsessed about their antihypertensive medication all day long, right? I posit that we should do the same thing with substance use disorder treatment. Some of the terms are a little different just because of the nature of the beast. Detox, that initial 3 to 5 day period where you're helping people's chemistry calm down. Treatment, which oftentimes in today's world includes medication specifically for a substance use, assuming we have the meds. Right now we only have medications that are FDA approved for alcohol, tobacco, and opioids. Okay. Then recovery, which implies a longer period of time. I'm not even hot on the word recovery because it means you're recovering from something. Some people don't have that something to start with. Okay? I took care of the kids at juvenile detention for the 15 years that I was medical director at the jail. Love taking care of those kids. And I would tell them all the time, I love taking care of you guys because I don't have any of you at home. Okay? But the thing is, a lot of my kids in detention never had a rich, full life to start off with. So sometimes recovery means discovery rather than recovery. But then what I want to propose to everyone here as well is this idea of flourishing. Okay, let's go back for a minute. Let's not go. There we go, back for a minute. What is a gold standard for treatment success in substance use disorders around the world? What is the endpoint that everyone measures?
Sobriety?
Close. Not that good though. Retention in treatment. Okay? And if you're looking at me crazy, you're probably thinking, well, that's not very high of a bar. Okay? If I had a patient with diabetes roll into my office, and I say roll into on purpose because the person's had 1.5 amputations, take your pick, of the limb. Okay, roll into my office, labs are out of control, 2 bed sores from being in the wheelchair all the time, but she makes it to my appointment. Do I call that a treatment success? No. Okay, that's how we measure treatment success in substance use disorders. We found them because they came back. They came back for more. The goal of treatment should not be more treatment. The goal of treatment should be flourishing. If we can start figuring out what that is, and now that I'm on the board of ARCHway too, I forgot, that didn't get into my intro, because I don't have enough to do, because I don't have teenagers at home. It frees up time. But the thing is that we need to redefine what treatment is, and we have to figure out how to measure it, right? Because if we want substance use disorders, much like behavioral health, to be treated with the respect of hypertension and diabetes in our country, we have to use language that other people understand, and we have to measure what's successful. So let's take a look at, again, Jan and Dan set me well up for this. Why is it, I think I might have skipped something here, let me see if I did. You can tell I really get thrown off when I have a new set of clickers. All right. Why doesn't everyone get addicted to everything? Or as the Stookie said, John got tagged. Why didn't the other 3 kids get tagged? That we know that we have internal and external factors that affect our health and well-being. We've known this for decades. This is something from the World Health Organization in 2004, where they talked about protective factors and vulnerabilities for people with serious mental illness. Okay? Guess what? Somebody repurposed this at Washington University about 5 years ago, wrote a big fancy paper and basically said, guess what? It's substance use too. Okay? These things on this list, these are the protective factors, not rocket science, right? But as I tell my med students, diagnoses are easy once you think of them, okay? We're not used to seeing all these in the same place, but if you look at these environmental factors, this ties very much into what we know now about trauma too, what we're learning about trauma. I spend a lot of times giving a talk also, this is your brain on drugs, this is your brain on trauma. Because the effects are very similar. But when you have a supportive family, good social support, positive life events, and then internally, you have self-efficacy, you're optimistic, you can resist social pressure. These are all things that, not any one of them, but they help protect you against a substance use disorder. And kind of makes sense, but we know it affects our biology because it affects our hormones and our cortisol level and all those things. Vulnerability, same kind of thing. We've known for a long, long time, for example, that folks with schizophrenia often have their first break between like 18 and 25 or so, 18 and 30. The more noise in the environment, the more chaos in the environment, the more unstructured the environment, that folks are going to have an earlier break. More rural, more supportive, more stable the housing environment is, somebody's going to have a later break. Okay? Same kind of thing when we look at substance use disorders. Environmental, yeah, availability of drugs, no brainer, right? But it's in St. Louis, I will tell you in the course of my lifetime, things have really changed. Part of that, cell phones, texting, social media. You don't have to go to the bad parts of town to get your dope anymore. You can text your dealer and go to the public library, okay? Or the nice shopping center, okay? Fentanyl. We know fentanyl 50 times stronger milligram for milligram than morphine. Because it's so strong, it's so variable. Do you guys see fentanyl here? Okay. It's one of those things that's kind of variable depending on geography. But I know in St. Louis City and County, 90% of the deaths last year were fentanyl-tainted heroin. Okay? But the thing is that these are all things, environment that can be create vulnerabilities. You don't want most of your folks who are recovering from alcohol to be bartenders, right? Or even necessarily to work in restaurants. Individual factors, we've talked about some of these already. Have you guys read about epigenetics, how that's becoming a popular topic now? We thought that our DNA was written in stone. We know now that through trauma, through substance use, through mental illness, our DNA can actually change its structure based on these kind of impacts that's creating stress in our system, elevating cortisol and adrenaline, and creating other problems. So that's one area that we find out too, that there are risk factors. Start mixing all these things together, and that's why one of the Stookie's children has a vulnerability to addiction, and probably the other 3 don't. But DNA does not go away, right? Which is why they're very concerned about their grandchildren. So these things, again, the epigenetic stuff is new. A lot of this other stuff isn't, but we haven't done a very good job of connecting the dots so that when we screen people for alcohol use disorder, we're not just screening that person, we're screening their offspring. We're screening their family members. So it's a different way of looking at things. Okay, our slide is there again. So, why medication first? I am a simple family doctor, okay? That's my version of the brain. Two things to pay attention to. The bottom part where you see the cerebellum, you see the brain stem, drug, sex, and rock and roll. That's where all our urges come from. The urge to breathe, the urge to eat, the urge to procreate, the urge that I was thinking, ooh, I could have a Bloody Mary on the flight in today, but then I thought, now I got to stay awake the rest of the day. I don't think I got a nap in there. So, something's got to control those urges. The prefrontal cortex, top left, frontal lobe, executive functioning happens there. Executive functioning is a part of my brain that said, no, don't tell the Southwest stewardess you want a Bloody Mary, because you've got a talk to do today. The urges and the drives that keep us alive come from the brainstem. I stole from my buddy, he calls that the lizard brain, because we call that the reptilian brain. Every animal has a brainstem. Every animal that breathes, that has a heartbeat, that eats, that sleeps, that reproduces, all has that basic brainstem. Where humans are different is the size and complexity of the cortex, particularly the frontal lobe, the executive function. I think my cats might be a little different because I think Michelle really has a highly developed executive function. I have to keep her away from myself. But the point is, that's what's controlling the urges that we have. That part of the brain, the wizard brain. So we have the lizard brain and the wizard brain. Okay. Simple family doctor, that's all. I don't think I tell my students they need to know more than that, but I'm old, so that's all I have to remember. Guess what? When those two are out of sync, guess who wins? Lizard brain, okay? So when you wonder why somebody you're working with early in recovery or while they're actively using makes bad decisions, it's because their brain is out of sync. The rest of my time today, I'm going to kind of take a turn towards opioids because it's one of the simpler systems to understand with neurotransmitters and all that stuff. Okay. Opioids activate the dopamine system. The dopamine system, the dopamine is a neurotransmitter, the chemical that is released when you hold a puppy. Okay? I used to say you hold a child, but then the med students would look at me funny. Okay, you hold a puppy and life is good with the world, right? Everything's sweet. Dopamine pathways are the pathways that get messed up between the lizard brain and the wizard brain when someone's actively using opioids. And we're going to drill down just a little bit into that in a minute. Okay. One of my favorite slides in the world, and I know I'm getting old because I've met this guy. So, y-axis and x-axis. But first, we're going to talk about Lego blocks. Okay. Everybody's played with them or has stepped on them, so you all know what Lego blocks are. Okay. Think of my arm, so we have Lego blocks in the back of our head. Think of my arm as a neuron, okay? A nerve cell. Nerve cells conduct messages from one nerve to the next nerve by little chemicals that move between them called neurotransmitters. Sound familiar? Okay. 6 common classes of neurotransmitters. The one we'll talk about with opioids is the opioid, endogenous opioids you've heard about, like enkephalins and endorphins. That runner's high thing they used to talk about, I think I experienced it once in my life. But we have natural opioids, okay? But when we put extra opioids in our system, oxy, perks, heroin, fentanyl, whatever, what happens is that the opioids bond to one of the receptors on the nerve cell, okay? One of these receptors, just like a Lego block, okay? When an opioid bonds to the receptor, dopamine gets released. Dopamine gets released, again, holding a puppy, life is good, okay? We need that feeling of calmness and stability in our systems in order to live our lives, right? Now here's the crazy part, folks. This is where science can drive Dan crazy running around the stage. Teaching high school before I went to med school, I can't stand still.
Love it.
Okay, got to keep them awake. All right. So Narcan reversal. What happens in a Narcan reversal? Here's our nerve, upregulated. We've got opioids like Lego blocks plugged into each of these. Narcan comes along. Narcan has a higher affinity, meaning the receptor will bind to it more than it will bind to opioids. Narcan comes through, kicks out the opioid in each of these receptors, and somebody goes into an immediate withdrawal state. Okay? Why do they go into an immediate withdrawal state? Narcan occupies the receptors, but it's an antagonist, so it doesn't push out dopamine. So you go from lots of dopamine going on to antagonist, immediate withdrawal. Make sense? All right. Now, let's look at our slide here. Not to give anyone PTSD from calculus. Y-axis, think of that as opioid effect. Think of that as dopamine level. Think of it as emotional well-being. The white zone is normal. The green zone is euphoric. Somebody's just a little too perky for their own good, right? Red is a withdrawal state. Now, the x-axis is time or use. Okay. We'll come back to the Lego blocks in a second here. But now let's look at that y-axis. Assuming everybody in this room has an opioid-naive brain, meaning that you're not on Percocet, Oxycontin, Methadone, Buprenorphine, something like that, except for the 5% of us or so who cannot take opioids because it makes us sick. And there's people go, what do you call them? I say lucky. Okay. But it makes them sick. Okay. Assuming you're not one of those. If I took a Percocet for the next few days, I would go from normal to euphoric to some degree after each dose. Okay? It would take care of my pain, but I would also get an extra dopamine push, right? Dopamine, because the Percocet would be occupying the receptors, releases the dopamine. I feel good. I feel a little too good. Okay. Now, what happens over time is that people go from oscillating between a normal and euphoric state to tolerance in the withdrawal state and a normal state. In other words, in simpler terms, at the jail, I would often ask my folks who would come in, even if I knew they had used that morning, when's the last time you got high? They'd say 3 years ago. Okay? Why? Because they've upregulated in their system and they're continuing to use to feel normal. That, I think, is one of the most important things for my students and my peers, because I do a lot of peer training as well, to understand. If people have been using a long time of a substance and have developed tolerance, they continue to use, particularly with opioids, so they feel normal. They've got to have the receptors occupied for dopamine to be released to feel normal. So then as we go on, our job, who are all of us in these health professions, we want to get people back into feeling normal again and getting out of this oscillating state. That's where medications come in. Medications are a way for the neurochemicals to calm down and for the brain to heal. I hate to say it, but that's all they do. If we could fix everything with medications, God knows in the U.S. we would have it fixed by now, right? But no, it's harder work, because if people are obsessed with cravings, which is one of the characteristic signs of opioid use disorder, if people are occupied completely with cravings, they're not going to be able to do behavioral change to move them forward. Jan and Dan and John talked earlier about when your brain's not working right, as I like to say, because it's been altered by the chronic use of opioids, you can't make good decisions. Why? Because your lizard brain is taken over. When people do stuff that is hurtful and painful, illegal, atrocious, I don't think it's because they're bad people. I think it's because their lizard brain is taken over and their cravings are driving their behavior. Okay. So that's the role of medications in a nutshell, but we'll unpack that for a few minutes. Okay. One of my favorite slides, and this one's for you, Dan, because I know he wanted this slide. What does this mean? Okay, y-axis, the same axis we had before. Opioid effect, dopamine effect, same thing, psychological state. X-axis, dose of medications. We have all of 3 medications FDA approved for a condition that kills over 150 people a day in the US. 3 meds for opioid use disorder, that's it. Why? Oh, little things like the Sacklers and other things you hear about on TV these days. Okay. Whole nother talk. But there's a lot of things that got put on hold in the US, including drug development, treatment development, pain management, that got put on hold because people like me were sold a bill of goods that says we're good with OxyContin and Percocet and morphine. We don't need to worry about other stuff. Okay, 3 meds. Here are the 3 meds. The bottom line, the purple, that just goes along the x-axis. That's naloxone, is the same thing as Narcan. Remember we talked about knocks out the opioids? No dopamine push. It's an antagonist. It's a Lego block that clicks, but it doesn't produce any dopamine. The medication that we talked about earlier today that John found success with, Vivitrol, it's a very similar compound called Naltrexone. Naltrexone comes in 2 forms, a pill form that you can take either every day or 3 times a week, and a depot formulation, arm or butt cheek. It lasts 21 to 28 days. What does that med do? It's an antagonist. Think of it as a protection against opioids. If I had Vivitrol on board right now and I took a Percocet, remember, my receptors would be blocked by Vivitrol. The Percocet would make no difference, okay? I would not feel the effect of Percocet. It also works great for alcohol use. I could drink a pint of whiskey. I wouldn't get drunk. I might not be able to walk a straight line or still have a hangover the next day because those are different receptors, but it would block the euphoria, okay? One of the people we mentioned earlier, one of my favorite people, Colton, who was featured on one of the short videos, Colton said that when he got his first Vivitrol shot, he had a vacation of 28 days to invest in himself. I often have Colton be on one of my patient panels when I teach. He knew that for the next 28 days, there was no point in him chasing after heroin because it wouldn't do anything. So it gave him a chance to restructure his life and his life activities. Okay. Now let's look at the other 2. Buprenorphine, brand name, Subzol, Suboxone, Subutex, blah, blah, blah. Okay, but I'll call it Bup because it's easier to say. And then Methadone, and everybody's heard of Methadone. Methadone and Bup are actually synthetic opioids. They're full-on opioids. Why in the world would you give somebody an opioid to treat opioid use disorder? Let's go back to our neuron. Okay. Remember, chronic use opioids, upregulated receptors. If somebody runs out of opioids, what's going to happen? These receptors are flapping in the breeze, waiting for that Lego block to come back and plug it up, right? That somebody goes into a withdrawal state because they're not producing dopamine and they feel lousy. And they're obsessed with cravings. What we typically have called social detox or abstinence-only detox, right? What we did for 15 years at the jail. Fortunately, now our county jail is getting some MAT programs, which is great. But unoccupied and unhappy. If we give somebody a medication that is an opioid, you can plug up these receptors again and produce dopamine so people feel normal. If people feel normal, they're not obsessed with cravings, they can engage in the psychosocial therapies to address all those other social determinants in their life. Okay. Now the real question, and this is where I get some people kind of upset with me, but life is short, why not? How long does somebody need to be on an opioid for them to be considered a treatment success? It depends on what you call a treatment success. If treatment success is retention in treatment, that you're showing up to your appointment, I guess it really doesn't matter anymore. Somebody can be on an opioid their whole life. Now, if a treatment success is considered flourishing, let's use the standards we use in every other area of healthcare, which is the lowest effective dose of the safest medication. Having the majority of people on an opioid for their whole life, in my mind, is not flourishing. Okay? So, that editorial comment, which someday I'll prove before I'm done. Let's go back to this. Methadone works great, but there's a dose response that is basically unlimited. How do people die from an opioid overdose? They stop breathing, right? This is a stop breathing crowd, I can tell. I always have a respiratory depression crowd and a stop breathing crowd. Stop breathing crowds are so much more fun. Okay. Stop breathing. That's why methadone has to be monitored very closely, because people can overdose relatively easy for methadone. And any of you working with methadone clinics, you know you have to go to an actual physical site to get methadone for addiction treatment. Buprenorphine has been a game changer because see where it flattens out? Take that plateau over to the y-axis at opioid effect. What that means is that there's a certain dose of bupe above which you get no additional opioid effect. The fancy term is called the ceiling effect. What that means practically is that there's been no deaths in the U.S. recorded of people dying just from buprenorphine. Now put it together with other respiratory depressants like alcohol and benzos and a few other things, then all bets are off. Okay? But this is why you hear a lot of people really pushing buprenorphine today. Because as an agonist, buprenorphine can help people's brains heal, let their neurotransmitters calm down, get therapy going, and since it's got that safety piece, that's why I spend a good chunk of my time training physicians, nurse practitioners, and PAs how to prescribe this so that we can normalize this treatment as part of primary care.
Question.
Yes?
So is the goal with the Suboxone or the Bupe to decrease the dose till they get off of it, or are they going to be on it for life?
I will give you your $20 here in a minute. Okay. Because that is the question that nobody's talking about, right? Because if we're upregulated and we're occupying our Bupe receptors and we're engaging in therapy, what should be signs of success in treatment? Stable home, stable housing, hold a job, get back together with your family, get custody of your children. Right, because these are all the kind of steps we would take for somebody to hit the flourishing point, right? Among other collaborators is, once somebody's life is better and they're optimizing all those different areas in their life, that's when we should talk to folks about the idea of an extremely slow taper. Why? We need to downregulate these receptors eventually to get back to normal, right? Nobody's talking about that yet because I think most people in the field are working really hard on the harm reduction piece because so many people are dying every day. But until we have conversations about this idea of tapering down an agonist, I can tell you from experience most physicians are not going to listen. Why? Because it doesn't seem medically responsible to put somebody on an opioid for the rest of their life. So thank you for that question. Okay. Yeah.
What about, I've seen babies
Yes.
overdosed, and they get, I'm not sure which one.
Bupe or methadone usually now.
And do they get these?
Absolutely, yeah.
Okay.
It can take 8 to 12 weeks sometimes. Buprenorphine is much better because there was a study called, no kidding, the Mother Study, beautiful acronym, best ever, which showed that kids, babies born with, now it used to be called neonatal abstinence syndrome, now it's called neonatal opioid withdrawal syndrome. Those people, like Dan and Jan were saying, decide on a name and stick with that. Quit changing it. There are people I know whose job security is dependent on changing the acronyms every 5 years. But neonatal opioid withdrawal syndrome, basically what you do is you provide some opioids to the baby until their receptors downregulate. Okay. Awful process, very difficult. Guess what works best? Grooming the baby with the mother. Who would have figured? Rather than putting him in an ICU, okay? So there's some good things coming out of that too. So the question then becomes, what med's best for which person? Okay. So let's briefly with the meds. Naltrexone we talked about, antagonist, comes in 2 different formulations. Methadone, agonist, very difficult unless you live somewhere where there's a methadone clinic. Because the first 30 to 90 days you have to show up there every day to get your methadone. It's a highly structured environment. It's desperately needed for some folks, but it's not easy to engage in. Buprenorphine, safer profile. Any medical provider who can prescribe meds can sit for the extra training they need to do this. And now there's generics available. If any of you are working with folks who are on buprenorphine, but money's a problem, if you've heard of Outreach, talk to me later. They're opening a substance use disorder benefit package. So it's going to be a game changer in terms of people being able to afford these medications. All right. So before I get here, let's talk about who might be best for each of these 3 meds. Because that's where people really want to know. What's the answer? And it's not a urine drug screen. People always want to use a urine drug screen to make every clinical decision for them, or at least to fire a patient. I learned from being a jail doctor, I couldn't fire my patients, so you have to learn to work with folks. What works best for each? Vivian Vivitrol, let's talk about her first. Floor nurse in a hospital, broke her ankle pushing a bed. Okay, you show me a nurse, floor nurse with a good back, and I'll be amazed. Okay, but pushing a bed, broke her ankle. She started physical therapy, but then it's like, my life's too busy. I have 2 kids. I have a job. I need to get back to work. She doesn't finish PT. She starts taking a little too much Percocet. She doesn't have a very bright physician as her doctor who kept prescribing it. So Vivian developed an addiction to Percocet. Okay, Vivian's 35, has a couple kids, has a job she loves, has a supportive husband. What age are we when our brain's fully developed? 25-ish, right? Okay. Her brain's fully developed. Okay. A lot of my med students, their brains are not fully developed, and I can tell on many reasons. But okay, Vivian's 35. First addiction. Vivian's somebody that we could probably taper down fairly quickly off of Percocet, get her on other pain meds, get her back to PT, but have her on Vivitrol for a little while. A little while, 6 months, 12 months. We don't want to rush somebody on or off these meds. Why would we want to put her on Vivitrol? If she's working as a floor nurse, she is around controlled substances all the time. The Vivitrol or the Naltrexone is a protective factor that she can work on her resiliency. She probably doesn't have a lot of psychosocial work she needs to do if this is her first addiction at 35, but there might be something going on. This gives her a chance to explore that. Okay. Now let's talk about Suboxone Sam. Suboxone Sam got in the parents' liquor cabinet at 15, pill heroin at 18, shooting up by 20. Okay. He wants treatment. He's 20. His brain is not fully mature. He's driven by cravings. He's somebody that needs to get those cravings under control. He might benefit from an agonist like Bupe. Okay? Allow his chemistry to calm down, let his brain heal, get back on that healing trajectory till his brain is intact. Get some therapy going on to find out why did he get into his parents' liquor cabinet at 15. Okay? As Dan mentioned earlier, you can develop a generosity of spirit doing this work, or you don't last in it long. Whether your work is as a caregiver or a physician. And I tell my students, if you don't understand why somebody is behaving the way they are, if you don't understand that, you're not asking the right question. So we need to find out, why did the liquor cabinet and the pill form heroin look like good choices for him? Okay? The goal in treatment for him, again, flourishing. How do we get there? Get those chemicals calmed down, allow the brain to heal. How long does that take? Hard to say at this point. We're trying to figure that out. but it's probably several months to maybe a year or two. Then maybe in time, we can taper him down, protect him for a while with Vivitrol or Naltrexone, and life is better. Methadone Marty. Methadone Marty, the only reason I'd start somebody on methadone in today's world if he failed buprenorphine, meaning that his cravings were not controlled up to that ceiling effect and he needs more opioid effect. He might need to be on methadone for a while for his brain to heal. What would we want to do with him? As life improves, move that on to bup, safer med, lowest effective dose, slowly, 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 so that we can help him engage in coping skills he didn't have before. Again, is this an oversimplification? Yes. But even something this simple is not in the literature yet. So it will be this summer, because I do have an article I've been working on with a few folks for us to start asking these questions. And you see why it's very different from retention and treatment. It's more, how do we work with folks to define what flourishing is for them? How do we help them get there? And then how do we have these discussions around medications so we have the med that's most appropriate at each point? Okay. We have talked some about this. Harm reduction, again, syringe access, Narcan distribution, all these things. Necessary but not sufficient. Keeping people alive is not the same thing as helping people flourish. Right now we're concerned about keeping people alive. And that's why a lot of this initial funding in the opioid epidemic is going to harm reduction. Because dead people don't recover. We know what the outcome is there, right? We have to give people the opportunity to engage, to where we move from harm reduction to harm elimination. Bup or Vivitrol is on board. That's going to protect people in most situations, even from if they use other opioids. So it's protective. We want people to get to the point where they can avoid harm on their own. So it's moving people, helping people move along those transitions. Things we've done in substance use disorder and treatment that hasn't worked for the past decades, going back to the turn of the 20th century. We've criminalized it. That doesn't work. We've moralized it. We've medicalized it, where we focus entirely on medications. Again, if it were that easy, we'd have it done. We've commercialized it. I'm glad that Jan and Dan are up there as curmudgeon-y as I am and set me up for this. Yes, there are no long-term advantages to 28-day treatment programs on sobriety. None. So why does somebody need to go to a residential treatment program if every other option has failed or their family needs respite? Okay? Those are two very important reasons. Okay? But the 28-day program came up. Why? Because insurance companies said, we'll pay for this much. All of a sudden it became a standard. Guess what? If somebody goes off to a 28-day abstinence-only program and they return to the home environment that they left and nothing's changed there, why would we expect a person to behave differently if they thought it was a good choice in the first place? So what other options do we have? We need to reassess the patient, their healing and improvement with the environment in which they're in. We need to have realistic discussions with our patients about this medication might help your brain heal, but what I'd love to see is if in 5 years you're not on any medication. We can talk about those. Physicians are really good about working with a patient right in front of them. They're not real good about long-term treatment plans. Other health professionals are. We need to have those conversations, which is why I love teaching in our interprofessional ed program at SLU. Physicians tend to want to fix things. If we could fix things, we could charge a whole lot more, right? Okay, people aren't problems to be fixed. We have to look at things long-term and start asking these questions and consider the kind of treatment cascade that my lady over there brought up, who's getting her $20 later. We need to have realistic discussions about what med's most appropriate at what phase in recovery and treatment. Caveats? Yeah, takes a lot of patience. We got to work with people where they are. We've got to train up our docs out there. I do a lot of work in St. Louis with SSM and Mercy, which is two of our big health systems. I just did a training with the VA about this topic, about how do we do the nuts and bolts of this stuff. The medication part is not the hard part. The hard part's the behavioral change, the establishing trust and rapport with your patient so that they trust you, okay? And sometimes it's not always me as a physician, sometimes it's a peer support specialist. That's a whole nother day that we can do here at Marion in the future. But the role of the peer support specialist on the treatment team. So, no one size fits all. There are tools in our tool belt. Unfortunately, right now, there's only 3 meds for OUD, so hopefully there will be more. We need to realize that trauma, mental illness, and addiction are intertwined. Nobody, okay, we'll finish up on this. Think back to when you were 4 or 5 years old. You're at a holiday. Christmas, Thanksgiving, you pick it. Grandma Betty or Aunt Hilda says to you, honey, what do you want to be when you grow up? Now raise your hand if you said, I want to be an alcoholic. Or I want to be in prison. Or I want an opioid use disorder. Okay? These are not a bad choice. Because it's numbing. Okay? So these are challenges we have, but I think they're challenges that we have that are doable. In terms of raising the bar, working together with people towards thriving, keeping this in mind. Let's raise the bar. Right now the bar is so low we're trip over it. Okay? In terms of substance use disorder treatment. To build on Jan and Dan's story, we have ways of moving forward. And I'm trying to build momentum with a lot of the groups I work with for pipeline and workforce development among healthcare professionals, but also in normalizing these conversations so that, as Jan and Dan said, we don't whisper about these things anymore. We talk about them. A few references. Here's some good SAMHSA stuff if you haven't used these routinely. There's a wealth of resources, then they're getting more and more useful as time goes on. And ASAM has a national practice guideline for use of meds, and that's the American Society of Addiction Medicine. Again, I will be around most of this day. I will sneak up probably during this next talk to sign up prescriptions in my car on my laptop back in St. Louis. But I'll be here for the rest of the day. If you want to talk, I have cards. Anything I can do to support the work that you're doing here in Ohio, that's why I stepped off of one board to get onto ARCHway's board, is because there's a lot going on now, and this is a unique opportunity to grab the ears of people. So, there you go. We have 2 minutes for questions.